recording. All right, good afternoon, everybody. Seth, are you still anonymizing? Because I'm happy to go first if you want me to. He's muted. Okay, I'm going to go ahead and go, then I'll start showing some. David, do you have any to show?
I have one case to show.
Yeah,
Okay.
no, I'm sorry. I said that would be great if you go first.
Okay, I'll go ahead and go. I'll show a few, and then I'll hand it over because I've accumulated several that I can show from the last couple of weeks. This first one, the radiograph's not too impressive, but there's some subtle airspace disease, mostly in the left upper lobe. And this is a patient that presented with productive cough and hemoptysis. And they presented to an outside hospital. And as you can see, this is almost a year ago. And so this was after that radiograph. So it's these are 5 millimeter slice thickness from the outside, but just some multifocal nodular areas of consolidation is the main finding, mostly in the left upper lobe. And you can see, I think there's a little bit of ground glass opacity throughout the left lower lobe. And there's also a small effusion on the left side. So, and at the time, I think this was just called pneumonia. I don't know. We don't have the outside hospital stuff, but patient got the usual, antibiotics, maybe got some steroids and whatnot, and then came to us and was referred for interstitial lung disease, 9 months later. And this is when one of my colleagues saw this, and this was the non-contrast study we had, and she had the old study. And you can see the findings are exclusively in the left lung. And there's a lot more volume loss now. And, crazy, this patient had a biopsy on the outside, a surgical lung biopsy. And it was something non-specific, like some acute and chronic inflammation or whatnot. But there's also a little bit of septal thickening and asymmetric ground glass, as we said, and there's some volume loss. And she actually called the diagnosis on the non-contrast study and asked the appropriate question was what intervention, or had this patient had a AFib ablation, and noticed that the pulmonary veins were pretty tight here. And it turns out the patient had an AFib ablation weeks before that other radiograph and CT. And just thought this was looked like asymmetric edema and chronic edema, like often we see with venous disease post, like pulmonary vein stenosis after AFib ablation. And oftentimes it's easier to make the diagnosis if it's just confined to a lobe, but this was the entire lung. And so they did get a contrast enhanced study, and sure enough, the pulmonary veins are both out on the left side. And so, it's always important to think about as a cause of asymmetric edema, and knowing the history or asking the appropriate question to get the history of the patient having a prior venous ablation or atrial fibrillation ablation resulting in pulmonary vein stenosis. So, but yeah, the diagnosis was, yeah.
Do you think that that there was infection on that first radiograph with the nodules?
No, I think that's when this started. I think this probably was hemorrhage, because they, even here, I didn't show this, but there's not, doesn't really look like much of a pulmonary vein, and it was, the procedure predated this study as well. But I think patient gets diagnosed with something, just based on the imaging and not putting the full clinical context into consideration. So I don't know. I mean, could they have had something else? Maybe, but I think this is just early asymmetric venous edema, and maybe some of this is hemorrhage.
Yeah, absolutely. Absolutely.
Yeah.
I think that's what it is.
Yeah.
Cool.
So, yeah. All right. Now this is quite the radiograph. It's funny. I had just the day before I had shown my residents some cases of pneumopericardium, and had, usually some of the biggest ones I've seen have been in the context of trauma, like gunshot wound or stab wound, or patients that are post lung transplant. This patient came into the emergency department with this amount of pneumopericardium. And as you can see, they have a port catheter, which does come into play for what this actually was. And I don't know why they had a pigtail pleural catheter. I think that it was just for pleural effusions, but um, rather large amount of pneumopericardium. And of course, it's in an actual space, not pneumomediastinum, and it's confined to where you would expect the superior recesses of the pericardium to be. And this is what their CT looked like. Actually, let me go to this one. This was the first, so this was a CT of the outside hospital a couple of days before that radiograph. And this is a PE study. And you can see there's, a moderate circumferential pericardial effusion. And, one of the things I hate about PE studies, and I think all of you hate about PE studies too, is just with the early timing of contrast, you can't see pericardial thickening, but, it's probably here on this one. And especially when patients come in with chest pain and the reflex is just to get a PE study, even though based on what literature you look at, like 5% of non-ST elevation MI chest pain in adults is pericarditis. Now, in this case, this isn't just run-of-the-mill viral pericarditis. And the important thing, which to take into account, was that this patient had a history of gastric lymphoma. We don't have any pre-treatment studies, but you can see the stomach doesn't look right there. And even on this study, right here, you can see a tiny little bit of gas kind of cheating up towards the pericardium. And so when they came to us, this is 7 days later, so 7 days after that. Now you can see, in this just nice venous phase, you see raging pericardial enhancement and air throughout the pericardial space. So it is inflamed and probably, frankly, infected pericardium, but you can, drive a truck through that hole that's now communicating between the gastric lumen and the pericardium. So, years back, I showed an esophago-pericardial fistula in a patient who had had esophageal cancer treated. This is a gastropericardial fistula in somebody with treated lymphoma. So, I don't know if there was pericardial involvement of the lymphoma, or if it was just that the gastric involvement, when it was treated, that it just left nothing behind and it created the fistula. But that's why they had pneumopericardium. So pretty dramatic radiograph and CT.
That's nice.
All right. Speaking of crazy radiographs, so this was just a couple days ago. Yeah, what do you guys think? This is a 30-year-old, and I'll tell you, this is the first one I looked at, and I was wondering if this was all, if she had some sort of big congenital diaphragmatic hernia that had never been corrected, just given the loss of volume of the lung and that, what looked like maybe a loop of bowel there. Have you ever seen a congenital diaphragmatic hernia in an adult? I guess that would be my question for anybody here. So, yeah, I don't know.
So what, Travis?
A congenital diaphragmatic hernia, like present in an adult, where you've got bowel in the chest as an adult, like resulting in lung hypoplasia.
Yeah, we do here. We have a lot of guys come across the border.
Yeah.
Have not a lot. I think I've seen one or two. It's not a large number.
Yeah. Well, it turns out that's not what this is. I saw this radiograph, so they actually went in and reduced the hernia, and clearly there's a normal sized left lung under here, and there's probably a little bit of re-expansion pulmonary edema at this point. But this patient presented with, abdominal pain. This is, oh crap, do I not have? Oh no, here it is. Yeah, this is the CT. So they presented to an outside hospital and were transferred here. And you can see this small bowel, most of her small bowel is in her chest. There's a little bit of wall thickening. Those loops are fairly uniformly dilated. And she had fairly acute onset of pain. And it looks like there's a little bit of stranding in the mesentery. So there was certainly worry for mesenteric ischemia or incarcerated bowel. And I think it's cool. You can see the mesenteric vessels as they go through this diaphragmatic defect. You can see the arteries like on both sides, but you don't really see anything going through this small defect. So this is, of course, this is a lateral hernia. It's not a Bachtelek or a Morgagni. And you're probably thinking, this is not congenital, which it wasn't, then what was her trauma? And I'll show you in a moment, but I just want to show the CT in a coronal and just see this narrow-waisted, hernia. They were able to go in and successfully reduce this and not have to resect bowel. It wasn't infarcted. But, interestingly, she had a CT 4 years ago, and you can see at that point there's a little bit of bowel in her chest, as you get the so-called dependent viscera sign. It's just fallen back posteriorly, and again, here's the defect. So it's not incarcerated at this point. And I think we all asked the question why it didn't get treated at this time, and because it was described, as a traumatic hernia. And the answer is here that they were doing this because of, she had unrelated symptoms and was pregnant at the time and was on the, I don't know if it was just the service that they were on, but it didn't get, treated at that time. And so now she presented with, this acute incarcerated bowel 4 years after that. But and I'll show you, we do have the actual trauma scan from 4 years prior to that. She was a motor vehicle crash. And I think, this is probably, and this would not be easy to call prospectively. This is probably the small diaphragmatic tear and a little bit of fat already pooching through there, but no bowel or anything else. So delayed presentation of a incarcerated, traumatic diaphragmatic hernia.
Impressive.
All right, now I need, this one's just a quick radiograph case. So right IJ line that was there, new left IJ line, left of midline, and I think this is only the second or third one of these that I've seen. You might think that it's in a left SVC. That would be the first guess. It's not going medial enough to be aortic. Certainly it could be extravascular, but other venous variants that we rarely see, and I think you guys agree, this probably has the typical course of what turned out to be an internal mammary vein placement. And it's often that they will go down vertically and then have a little bit more of this medial deviation when they start to travel down more in line with the internal mammary vein. Would you call this with 100% certainty on a portable in the internal mammary vein? No. But that's what it turned out to be. And you can see they did a PE study or unrelated study, but you can see it right there. And then you kind of lose it in the contrast column, but then you can see it in that internal mammary vein and how that vein, as it's communicating with the brachiocephalic or subclavian vein, is a little bit more lateral, and just like the artery, kind of deviates more medial as it crosses down along the sternum.
Yeah, we had a nice one that was in a superior intercostal vein that took a little kink at that area, but then went the other way, went laterally, kind of took a kink right by the arch and went a little laterally and then down, versus that medial. But it was, I
right, it would
try to find
kind of wrapped around right there and then went down.
Yeah, but it was, that kink is so, it basically just, it was, anyways.
All right, and then here, so this is one of the more interesting smoke cases I've seen in a while. And there was quite a bit of discussion. So this was an outpatient, and this was just, aneurysm detected on echo or something. So they do a CT. And this generated a lot of discussion because there were many people saying, oh, that looks like a type A dissection. And I was like, there's no way that's, I don't think that's a type A dissection. This is an outpatient who's asymptomatic, and this is all smoke. Because the question was, somebody raised the possibility of a dissection with an intimal intussusception, like just a circumferential tear and everything balling up. And, I think we've seen enough of these. This just all looks like aortic smoke. It has that typical appearance, it's swirling, it tends to be more along the undersurface of the aortic arch, but because they have an aneurysm, they just have a lot of just little eddies and weird areas of flow in the arch. And you can see it's even going up into the carotids. Now, the nice thing is that we had, there was a follow-up. This was a month. This was also at the outside. But you can see this clearly, the stuff in the ascending aorta is not a dissection. And this patient was asymptomatic. And the stuff in the arch has changed enough, and you can see it's high enough attenuation that this is clearly all smoke. So no dissection there. And this patient did undergo an aortic replacement. You can see they've had a prior circumflex territory infarct. And so that's one of the reasons I think they have all the smoke, is just slow flow and reduced left ventricular outflow. And when they had their repair, they ended up with an intra-aortic balloon pump for some time. And this is post-repair, and you can see they have a pulmonary artery catheter still at this time. They did an aortic valve ascending, they did a mitral valve as well. And apparently, right after they took out the intra-aortic balloon pump, which was right before this CT, the patient developed like severe onset of abdominal pain. And so they got this study, and looking at this, it's I first saw that and I was like, that kind of looks like a little bit more smoke. This looks like smoke, but notice their superior mesenteric artery is abruptly cut off right there and doesn't really reconstitute. And you've got pretty good flow to the rest of it. You've got some opacification. And so this patient actually went for a thrombectomy and was having issues with ischemic bowel. And so the thought was that, I still didn't know. What do you think? Do you think this is real, or do you think that's additional area of smoke?
That looks real to me.
Yeah, it's very sharp and discreet.
Yeah, and it's not a dissection. It turns out it's just a little bit of thrombus. And here's the follow-up. Yeah, so I mean, I don't know if they injured the wall of the aorta with the intra-aortic balloon pump, or if it just accumulated next to the balloon pump, but the thought is that when they pulled it, it just dislodged some thrombus into the SMA, which then they were able to successfully remove. But I have not seen a case of like acute thrombosis after balloon pump. Have you guys?
I don't remember. I don't think so.
Yeah, I don't know, but obviously patients that get balloon pumps are sick. This patient clearly had reduced output. I mean, that's why you put the balloon pump in, so it would predispose presumably to clot formation. But so a case of smoke, not dissection, but then actual thrombus in the aorta. And this last one I'll show, this is another balloon pump. And so this patient, so their story was they actually, you can see the balloon pump, it's tips a little bit below the aortic arch. So they came in with chest pain, went straight to the cath lab. They had an ST elevation MI, and it was actually an LAD occlusion that they placed a stent in. Then they placed the intra-aortic balloon pump, after the procedure, and after that, the patient developed, worsening chest pain. And this was actually, one of my colleagues actually described this and said that this descending aorta, the balloon pump looks a little bit lateral, descending aorta looks pretty dilated, a question whether or not there could be a dissection. And which, I think was a fantastic call. Now, by this time, so here's the subsequent CT that was done, and you can see on the arterial phase that there is in fact a dissection. There's no contrast in the false lumen in the ascending aorta, though, so there's no entry tear there, and the only entry tear is right here. And so, this is where the contrast is getting into the false lumen, and right, I think right near where that tip was, and remember that tip was more lateral. So I think, and we've seen this before, just dissection from an intra-aortic balloon pump. But interestingly, by this time, the intra-aortic balloon pump had migrated inferiorly, and it was a femoral approach. And you can see, I've got the abdomen, that it's actually, it's coming in from the right side, but it doubled back into the left femoral artery. And so it's kind of kinked and then coming up into the abdominal aorta. And I've shown one and there have been a few case reports of axillary approach that migrate too proximally, where they fold or kink in the ascending aorta and then go down the descending aorta. But I have not seen this before, mostly just because we don't image that many patients with femoral approach intra-aortic balloon pumps, or at least if it's in the abdomen like this, you don't see it in the chest.
So Travis, the coronary surgery was a stent placement?
Yes, and yeah, and thanks for asking that question, because that reminds me. Yeah, so there's the stent in the LAD, and I checked. They did a radial approach on their cath, so I don't think that they injured the descending aorta in the cath, since it was via radial approach. But there is some, while there is no entry tear in the ascending aorta. Yeah.
That hole is very focal,
Yeah.
and often you'll see multiple at all of the intercostal origins. So that may not necessarily be the original tear. Chances are this was IMH that then extended.
Well, except, you could see the intercostals, right? And mostly with IMHs, right? You're talking about like branch artery pseudoaneurysms where you see the intercostals.
No, it's more of a separation of. You'll see it at each of the intercostal origins. There will probably be multiple if you scroll through and track at the levels of the intercostals.
Yeah. Well, right, and that's like has been described as the Chinese ring sword sign, right? That's what you're referring to? Because they did go to surgery, and this was confirmed to be the entry tear.
No, that's a tear. That's an entry. It's probably a one-way tear.
Yeah. This was the site.
Because he doesn't have. Yeah.
Yeah, I think you're describing like when you have intramural hematoma medially, and you'll see, the contrast through into the portion of the intramural hematoma where the intercostals come off. Yeah.
You'll see this in all dissections or IMHs. Actually, in the IMHs, you may see them as little puddles of contrast at each of the origins. Sometimes if there's less flow, this one has more flow, so it tends to show as little jets. You'll see this also angiographically and also on 4D flow. You'll see each of these little, they're sort of like a ring sword sign or something. There's some sign that people have described that's sort of related to this entity.
Right, but I think this is not the intercostal, because and I agree, and yeah, you could have lots of entry tears and communications and fenestrations and dissections, but like this was thought to be the culprit cause of the dissection, because the patient's aorta was previously normal. So this was, an iatrogenic dissection from the intra-aortic balloon pump. You're suggesting you don't think it is?
No, I don't think so. I mean, if you scroll through that, it's just a pinpoint, right? It's not or is it a line? It looks like a pinpoint. So the intercostal at that level will arise at that location. What about the ascending? It looks like there's quite a extent there. How big was the ascending aorta?
Let's see.
This was surgically proven to be an entry tear there.
Yeah, it was surgically. This was surgically proven to be the entry tear. There was no entry tear in the ascending aorta.
So Travis, they looked at the ascending aorta. They saw it.
Yeah, they repaired the ascending aorta. Yeah, there was no entry tear in the ascending aorta. They specifically said that, and that's why. Yeah, they said the entry tear was in the proximal descending aorta along the lateral wall.
Oh, I think actually that's not the location. If you go up higher, you can see a little bit. Come down again. There's motion artifact, but right at that location, the posterior aspect there, that looks like a little bit of brighter contrast. There's definitely more.
There may be
artifacts. So it's hard to tell, but
like this is an intercostal here. I agree. That's an intercostal there. Yeah, this is too lateral for a takeoff of an intercostal, though, right?
Well, the intercostals can separate a little bit, but that's so pinpoint. It's just, I don't know. It seems unlikely, but anything.
Yeah, this is like the third case I've had just like this, though, from balloon pumps.
Yeah. Anyways.
Yeah.
So Travis, it doesn't bother you that that's a really hefty cuff around the ascending aorta? So this is all retrograde extension of intramural hematoma from this descending aortic entry site, and all the way back with that degree of swelling in the wall of the ascending aorta. That doesn't bother you as discrepant?
Well, wait, sorry, say that question again.
Well, it just seems to me that there's such a large amount of intramural hematoma around the ascending aortic lumen
Yeah.
that it's hard for me to explain that as a retrograde extension from a distal site that you have demonstrated, which makes me think that there might have been ascending aortic involved, damage as well.
They inspected.
But
the
if there
ascending aorta.
was, at least if there was a clear entry tear, it would be pacified with contrast during the early arterial phase, unless that entry tear closed off.
Yeah.
Which they would have seen surgically. There was no, the ascending aorta was intact. I mean, in terms of the intima.
Okay,
Yeah.
so they did a sternotomy. They did a median sternotomy to see the ascending aorta because
But they did
if they just
they did ascending and hemiarch replacement. I can pull up the operative note.
So did they do a left thoracotomy too then to get to the descending part, or do they not need to do that?
I don't think they need to do that. I mean, they exposed the entire aorta. I'll pull up the operative note. This is my last case. I can pull it up while somebody else goes.
The thing is that to see the descending aorta, you have to do a left thoracotomy. To see the ascending aorta, you do a median sternotomy. So I'm not sure that one incision shows you both.
If you're exposed,
well, they clearly are going to replace the root here.
Yeah.
Yeah. Okay.
Yeah, I don't know how big if they have to do a left thoracotomy as well too, it's exposed to do a hemiarch replacement. Yeah, but
that's a good point too, because without a left thoracotomy, I don't think you can look that far down in the descending aorta to find that pinpoint location.
If you use IVUS, you can. I mean, I don't know if it. Yeah. So.
Okay.
But I mean, you could certainly. Yeah, and
Mm-hmm.
I mean, obviously, you can have retrograde extension of type B dissections into the ascending aorta. I mean, they're unusual, but
Yeah.
It's
just it's so fat.
Yeah. No, I agree. And the other one I showed a few months ago was, a pseudoaneurysm that developed in the aorta, like right in this location from the tip of the balloon pump poking through. So it didn't even extend into being a dissection.
All right, Travis, I can go.
Sure.
This one is somewhat of a, when you share it.
Yeah.
The first one is somewhat of a case with also a consult. The case portion, well, the clear portion, as you can see, there's, it's a non-con, but you can see a massive PA, a small right PA, and a big proximal LPA. And this was a case of known congenital PS in an older patient. That's interesting-ish. And then the question was, what do you think of these cysts? So she's older, she's 58. A lot of these cysts are somewhat along some of them are along the underlying architecture of the lung that kind of have a lentiform shape. She doesn't have a history of BHD. They're only in the lower lobes. There's nothing in the upper lobes. I mean, there are a few, but it's definitely lower lobe predominant. You can see a couple on the fissures here. But she doesn't have any signs of Birt-Hogg-Dubé. What else? I mean, she doesn't have any connective tissue disease or collagen vascular disease, suggest LIP or anything like that. I just didn't know what to make of these cysts.
So you can't see anything in the kidneys if you scroll down?
Yeah, the kidneys were fine.
Okay. And did somebody knowledgeable look carefully at her skin for fibrochloromas?
No. So they're still working her up, but the initial report by the internist says no evidence of BHD, but yeah, it wasn't. So the answer is no.
I think she needs a folliculin gene, test.
Yeah.
Yeah, because I said it looked like BHD. But okay, good, because that would have
obviously important genetic implications for her family too.
Yeah. Okay, good, because that's what I suggested. And then here is kind of an interest. So this is a pacer. I'm just going to show the lateral. So the patient had a pacer lead, and it was normal-ish. Well, it's normal, what's interesting here, and I don't know if this has anything to do with what subsequently happened, you can see the RV lead's pretty static. You can see the RA lead, it's blurry. The rest of it's not motion. The rest of the lungs are crisp. But you imagine maybe this wasn't seated very well, given how blurry it is. So the patient comes back, and this is a year later, and that pacer had turned backwards, and unfortunately it wasn't called. And now we are a couple of years later, many years later, and this thing had migrated presumably through a PFO. So it's right in the region of the fossa-ovalis. You can see a little bit of tissue here where it's hard to tell if that's streak artifact or a little bit of that unfused fossa-ovalis right here. But anyways, this thing had gone through the septum in the region of the fossa, probably through a small PFO, and it got into left atrium. And he's actually been like this now for over 3 years, and just coming to real light. So fortunately, no major catastrophic issues with this, because obviously it's not good to have a nice thrombogenic surface in your left atrium, let alone one poking on the roof. But
so they couldn't tell from the EKG that it was it potentially pacing the left atrium, or?
you know what? It's so random. I don't know the ECG reports. I know that the interventional cardiologist was like saying it was in the left atrium, but there was there's a radiology report saying it wasn't, and he had echoes that said it wasn't, which is shocking to me. Even on echo, they said it was fine. He's like, it doesn't make any sense. And then he got the CT, and lo and behold, on the CT, it was not in the right place. So I don't know. But he had been like that since 2018. But so this is nothing special about this case. A nice Flovan catheter, classic pulmonary hypertension. It's just one of the nicer blushes that I think, I call it whatever people want to call it. I call it periarterial or blushing. Now, where you get these, we've seen it 100 times, and it's a very nice sign of PAH. I don't know I've seen it in any other thing besides PAH. Maybe some cases of what used to be called, PCH, pulmonary capillary hemangiomatosis, but they tend not to be as large as this. They tend to be a little bit smaller nodules. This one's relatively diffuse, very corkscrew vessels. And I'm still trying to figure out what this is. The pathologist, when we get these explants, because this is a pre-transplant workup, they always say there's nothing wrong. And we've talked about this, they cholesterol granulomas. They swear they're not plexiform lesions. They're too big to be plexiform lesions. Now, interestingly, we submitted and I should have pulled up the old cases, because I would like to prove this. We submitted this paper on CTEPH a while ago. And the point of that is not about that. It's that we said that, we mentioned the finding. Sorry, this is coming out blurry because it's during it's a lung window, but you can see a very nice nutmeg liver from the passive hepatic congestion with this macronodular cirrhosis. Anyways, someone had written in a response that this was actually related to vasodilatory therapies that they get, that these blushing is actually due to the vasodilatory effect of the medication, and that we tried to find a reference for that. I couldn't find a reference for that. But lo and behold, I should have pulled up this old case, but I now have 2 cases that look like this, that before they went on their vasodilators, they did not have this degree of blushing. And then after they went on the vasodilators, within 6 to 8 months, this blushing really became more prominent. So I'm not sure who wrote the review, because it's anonymized, but it was an interesting suggestion I had not heard before, and kind of makes sense that maybe this really is a vasodilatory effect. I don't know. And it may also help explain why the pathologist, when I'm bugging them like crazy, saying there has to be something around the pulmonary arterioles, they say there's not. It looks like pulmonary hypertension, but there's no clear things in the interstitium alveoli. Anyways, that was just I don't know if anyone else had heard that before. I just thought it was a very interesting comment that someone made.
You know, our pathologists, in cases that look just like that, Seth, you used to diagnose plexiform arteriopathy all the time. I mean, he saw it. I don't.
No, they have, well, the issue is they all have plexiform arteriopathy, right? These guys all have type 5 lesions associated with pulmonary hypertension, or PAH. I mean, they all have plexiform arteriopathy. Every single one of these people go to explant. The question is, you know, how do you say that, you know, the plexiform, there's so many of, you know, the plexiform arteriopathy is, they're scattered, right? They're not, it's not every vessel has a big plexiform lesion associated with it. And in these cases, there's just diffuse peribronchial or periarteriolar ground glass. So there's no doubt this person has plexiform arteriopathy, but if that's coinciding with what we're seeing, it may be. I just haven't been shown that by pathologists now at 2 places where I bug the crap out of them. But it may be right. I just don't know. So this is one of the more fascinating, no, I don't know how fascinating it is, but to me it's interesting. Case of, is this the whole chest? Do I have one of a whole chest? Oh, I do, but it's a coronal. And that stinks. Let's see, is this the whole chest? Okay, this is the whole chest. Pulmonary atresia, intact ventricular septum. I just am fascinated by coronary sinusoids. I don't know why I find them so fascinating. I think it's partially because no one really knows why they form. But this is one of the more impressive cases of coronary sinusoids with these very massive, both the LAD and you see the LAD coming here and the RCA. So usually it's more commonly involving the RCA, but the LAD can be fed or feed off of these sinusoids. So you can see both of them in different areas. This is the LAD right here coming in, and then down here is the RCA feeding, and you can see getting very aneurysmal, and you can see both of them just making these connections with the right ventricular chamber, which itself is kind of there's really no drainage to this chamber, right? I mean, the patient has tricuspid, all these patients invariably have tricuspid atresia, or is very, very, very severe tricuspid stenosis where there's almost no flow. They have pulmonary atresia, so they have a somewhat developed ventricle. And for some reason during embryology, these coronaries form these connections with the chamber. Presume maybe to drain it. I don't know. I don't understand it. It wouldn't make sense to drain it because that would be the coronary veins. But it's just, this is some angios just kind of highlighting the, maybe it won't work. Will it work? There we go.
So,
you know,
so Seth, this is a case of RV dependent coronary circulation, right?
Yeah, so you do not want to decompress this chamber, because in this case, you would actually probably not just give a big RV infarct, you probably kill the patient, because you'd already, he would presumably have a big LAD infarct as well. And yeah, you do, and the reason they don't, so when you have an intact ventricular septum, ideally they want to create a kind of a single ventricle, right? They want to take that RV volume and function and get it to contribute, because it's essentially a single ventricle, but they can't decompress the RV because of the sinusoid. So normally they like to create a bulboventricular foramen or, iatrogenic VSD or communication, but in this case they can't, because if they do that, they decompress the pressure, and then these coronaries will basically get a significant drop in forward flow, and the patient will have massive infarcts.
So Seth, I don't really understand it. So this is new to me. So does the coronary artery not have a normal aortic origin?
No, it does. So I have cases where they don't. I have cases where I've shown many years ago a case of a RCA that did not have a normal communication. It literally arose from the sinusoid, and that was confirmed on surgery and catheter angiography. Most cases, there is an origin from the aorta. So here's the LAD from the aorta, and here is the RCA from the aorta here. And then they form these networks, and it's much more, the communications here may just look like one vessel feeding it, but if you did a cath, you can see that in fact, I can pull it up again, there's lots of little tiny vessels and collaterals, not only these big aneurysmal vessels, but a lot of portions of the coronaries feeding into this chamber. And again, why that happens, I'm not, you look at the papers I've read and it seems to be kind of a mystery as to why this develops in these people with pulmonary atresia, tricuspid atresia, and an intact ventricular septum.
So why is it a bad thing though to diminish the blood flow to the right ventricle? Because that's not going.
No, it's not diminished if you decompress. So if you this RV is under a substantial amount of pressure.
I see.
If you decompress it and you lower the pressure,
okay,
then you
increase the shunt.
Mm-hmm.
Got it. Okay, got it.
Yeah. So, because normally they want to decompress this and let the RV and LV act as a single ventricle, but here they can't do it.
Super. Thank you.
And then this is just to go with Travis case. I wasn't going to show it, but it's just a nice correlation. This is a patient who had a very complex PAPVR that they tried to tunnel through actually the SVC wall and then through a baffle, supposedly in the right atrium, which I had not seen, and into the left atrium. And you can see here that it goes away. So here is the PAPVR that they baffled in. You can see in the right hilum, it just is gone. The right middle, there is an accessory right middle pulmonary vein that drains the right middle lobe. There's the right lower pulmonary vein, right inferior pulmonary vein. But just to show that same kind of, before I even looked at the veins, I'm like, oh, that's not good, because you see the unilateral asymmetric septal thickening and edema in the, with a history of a PAPVR. The first thing I said, oh, that it must be, or I better look very closely for an obstruction. Now, single veins, the body does pretty good at, I don't know, I haven't seen, I think I maybe have one case of a bad venous infarct with one vein going down, but usually the venous system is pretty good at getting into the other veins that are open. So, you'll get some asymmetric edema, but the patient is completely asymptomatic from this, because presumably it's just draining either through the veins in the pleura or making its way towards, through little collaterals into the right middle lobe or right lower lobe for other venous drainages. But yeah, you can see there's really no edema anywhere else except that right upper, or septal thickening, I should really say. All right, Dave, you want to show your case?
See, I'll make David presenter. Thanks. David, did you see the request to present? You're muted if you're trying to talk.
I saw it, but I got this thing telling me I have to give it privileges to
Oh, no.
assess. I thought I did that before, but I guess I have to log back in to make that happen.
So I pulled up the operative note. So they did an ascending from the sinotubular junction and did a hemiarch, and the rereading the note. So they inspected, there was no entry tear in the ascending or the arch that they could see. He commented that the entry tear was in the descending aorta as seen on the CT. So he was not able to actually see far enough to see that, that site of where the contrast was going into the false lumen.
Okay. Travis, can you give me permission again? Maybe it'll work. I don't know whether I need to log out and log back in to make it work.
Yeah, you may. Let's see. Here, I think I have to present myself and then I can give it back to you. Let's see. I'll share that, and then I'll go back to you. Okay, make.
Okay, I'm going to restart.
Okay. Since it was mentioned, I was pulling this up too. This was like one of the original articles that talked about this Chinese ring sword sign. And like you were saying, yeah, these are all of the intercostals. I think the difference here is like this is an intramural hematoma, like the case I was showing, and maybe it's just because I had it windowed differently. But this is dissection because there's actually contrast in the rest of this too. I just had it windowed where all you see is that little, that little jet of contrast. So I think that's the main distinction here that I would say. I don't know. What do you guys think?
I think it's an entry tear. I mean, that's how I would, honestly, that's how I'd read it.
Travis, shall we try it again?
Let's try it. Let's see. There's two of you. Let's see. I'll try this one.
Try the other one.
Oh, come on. This is frustrating. Let's see. All right, I'm going to try this again. I'm going to stop sharing mine, and we'll try this. No, I can only try one. The other one's just audio. Is it not?
Okay.
Is it not working?
Okay. So we seem to be stuck. So
Okay.
we'll just defer until next week then.
All right. Well, we'll see you in 2 weeks. Happy Thanksgiving, everybody, right? Anybody else have anything they want to share? We do have a couple more minutes. All righty.
I can try to come back in if you don't want to wait. If you're willing to
Oh,
wait.
I don't. It's up to you. I mean, we can just do it in 2 weeks if you want.
Okay, let's do it in that.
Okay.
We'll do it later. Thanks.
All right. Happy early Thanksgiving, everybody. Thanks.
Thank you. Thanks, everyone.